broader treatment program for schistosomiasis. And we've got new ideas now for new resources in 2008, or to quote Ralph Waldo Emerson, we need to simplify, simplify, simplify. So we're using our new donation this year to treat all school-age kids in Plateau and Nasarawa. We're going to use triple drug administration. That means we'll give all three medicines at once, but only to the school-age kids will they get praziquantel. So they won't have too much of a handful of, it'll be 2 extra tablets. We'll get it done in a single round. We'll be less focused on mapping results, and we'll forego community-wide treatment with praziquantel. Now we're only focusing on kids in our mass treatment program. This is a curve of how our treatments have looked since 1999 with praziquantel, at most 200,000 treatments per year, and this is what we're going to do this year. We're aiming to treat 1 million, and this is a big challenge. The medicine's in the port, and we're going to start doing this very soon. Let me conclude on my Nigeria piece. Integrating LF and river blindness programs at the district level was comparatively easy. LF took over from the river blindness as a platform program due to its size, but this elimination strategy will mean we'll lose the platform sometime in 2008, and what will we do? Woe is us if that happens. Conclusions related to river blindness, well, the integration was difficult because praziquantel was not donated. It cost a lot of money. We had to do a lot of assessments. The mapping took a long time. Some communities were don't treat, some were treat everyone, some were treat just school-age children. It really complicated our lives. And the delivery of praziquantel had to be as a separate dose. And now we've gotten around all of that, and we're going for 1 million treatments in 2008. Let me try and wind up with some of the future challenges. We've talked a lot about bundling and neglected diseases, but grassroots services is a key element that I didn't talk about. And I want to point out that the way we do this is through fostering partnerships at the community level and using community volunteers in these programs. It is those volunteers who are responsible for picking the medicine up at a central location and getting it to the end of the road. This mobile distribution business is not sustainable. What's sustainable is a community volunteer with a Chinese bicycle. And I think you can imagine that when infrastructure looks like this and your Pajero stops at that bridge, you can imagine the volunteer, he or she, picking up her bicycle and forging that stream, getting on and carrying on with the tablets for the community. That means people really have to understand what this is about. They not only have to buy in, but they have to understand how to direct these programs and get the medicines out in a safe and effective manner. This is community-based, not facility-based. We're not looking for outreach from local health centers. Community people are doing this. And to quote Mark Twain, that's the difference between government and individuals. Governments don't care, individuals do. And our focus has been on the very strong traditional kinship clan system to distribute medicines to family and blood relatives. This is something that in these traditional systems is an obligation when people are convinced that this is important to their health. It's a joyful obligation. And I've worked a lot with an anthropologist from Uganda, Dr. Moses Katabarawa, in developing this distribution system where we found very closely that the communities that tend to succeed in distribution of these medicines are those based on blood relationships and blood distribution, clan distribution systems. And those that don't are the ones that don't take advantage of those great African systems. Well, now we're in the midst of a new Bill and Melinda Gates Foundation grant on integration, where the Bill and Melinda Gates Foundation wants us to cost all this out, that whole DALI thing. They're very interested in this hypothesis. Community-based disease control programs increase the effectiveness and reduce costs, easing the strain on these horizontal public health systems of the African countries. Integration will improve health of as many people as possible at a cost that can be sustained for as long as necessary. Kind of a tough, testable hypothesis, but that's what we're in the midst of doing now in collaboration with CDC and Emory economists. And we're also involved in using the same system to distribute long-lasting insecticidal bed nets because they are an adjunctive a tool to use against lymphatic filariasis as we try to eradicate lymphatic filariasis because mosquitoes transmit that parasite. So treating as well as providing bed nets gives us two tools against that condition. The last thing we're going to look into is going to be another drug donation program against trachoma, a blinding disease. This is a bacterium, so I'm not going to talk about it. But Pfizer is donating a medicine called azithromycin, which can, in 3 rounds, 3 annual treatments, if done right, can probably eliminate blinding trachoma in these places. Well, so I've talked about bundling, I've talked about grassroots services, I've talked about battling the neglected tropical diseases, and we have journeyed to Africa. I want to thank a bunch of people: government, villages, University of Jos, CDC, Emory, the Gates Foundation, the pharmaceutical companies Merck, GSK, and I hope soon Merck when we get the medicine out of Lagos, Praziquantel, Izumi, the Lions, the World Bank, APOC, the African Program for Onco-Control, APOC. And I just want to give just two reflections for the students here about tropical diseases as you climb the mountain toward your career. A very important person in my medical school career, Dr. Ben Keene, a great American tropical disease specialist, said the following in his article, Never Go Back the Way You Came. When a student asks me today about going into tropical medicine, I tell him or her this: decide what field you want to go into, master the specialty, then when you go to the tropics, you can bring special knowledge with you. The basis for eventual success in tropical medicine is temporary restraint of your enthusiasm. We all know that you guys are very enthusiastic, so to quote from another great public health figure, Dr. William Fagey, former director of CDC, I encourage you all, while you're tempering your enthusiasms and studying, to don't forget to be globalists, be activists. If you're looking at science, try to be practical scientists. Look for simple solutions, be confident, and be focused. It has great rewards, like these chickens that I routinely get in Nigeria. So it's a great pleasure to come here. It's a great, I'm really pleased that my daughter is a bulldog, and maybe I'm a bulldog too, and congratulations, and thank you very much.